Hi and welcome everyone. This is Richard Mollett with the Long-Term Care Community Coalition, and welcome to our program today, Vaccination in Long-Term Care, Safety, Efficacy, and Residents' Rights. I welcome you to our program. Next slide, please. So I thought I'd provide a little bit of information about our organization, the Long-Term Care Community Coalition. We are a nonprofit, nonpartisan organization, and we're entirely dedicated to improving care and quality of life for residents in nursing homes and other long-term care facilities. We also are home to 2 local long-term care ombudsman programs in our home state of New York. Our focus is on, again, on people who live in nursing homes and assisted living. And what we primarily do, and we just celebrated our 31st anniversary in December, is we do policy analysis and systems advocacy on both the state and the federal level. And we are also, over the past 10 years especially, have been doing more and more programs such as this to educate and inform consumers, families, long-term care ombudsmen, people who work with residents and with families, as well as other stakeholders. I'm the organization's executive director. I've been with LTCCC for 18 years and executive director for the last 15 years. Our website, again, is nursingHome411.org. And again, to sign up for alerts, please go to nursingHome411.org/join. A few housekeeping items before we get started. This program is being recorded. If you have any questions for our panel today, any questions for the program, please post them in the Q&A. You are welcome to use the chat for discussion, to make comments, etc. But if you have a question, and we're going to leave a lot of time at the end for Q&A, please, again, you must post it in the Q&A for us to see it and be able to respond to it. And then lastly, I just wanted to mention that we are unfortunately not able to offer closed captioning for this program as we normally do. Because of the overwhelming response, we are also running this live on Facebook, and we're unable to do both. So a quick update on, on what today's agenda is. We're going to provide, a quick update and some links to resources, then a presentation on vaccinations, and as I mentioned, we're going to leave a lot of time for Q&A. Next slide, please. So what I want to do is just provide you all with some background and some information and links to the resources that, that we provide and that we have collected for others. So this is our website, nursingHome411.org. Again, you could see we have a learning center. We have a data center. We publish on a regular basis information on nursing home staffing, on nursing home enforcement, on important quality indicators, etc. And then we do provide a number of news items and reports. And as I mentioned, those of you who sign up for our alerts will get alerted to those as well when they come out. Next slide, please. I just wanted to quickly show here, if you click on one of these titles, Learning Center, Data Center, etc., you can see what is provided. And so we have coronavirus resource page, we have our webinars and events. So a number of people have already asked if this is being recorded. It is being recorded, it'll be available, I would say, hopefully by the end of this week, if not certainly by Monday, on our website here on this page, as well as on our YouTube channel. We have an excellent, I have to say, excellent podcast series hosted by our Director of Policy and Communications, Eric Goldwine. It's really, really interesting. If you have 20 or 25 minutes that you want to learn about something relevant to long-term care, I strongly urge you tuning in. We have a Family and Ombudsman Resource Center, a nursing home, abuse, neglect, and crime reporting center, assisted living information, fact sheets, etc. Next slide, please. This is our coronavirus resource page. So you can see we collect a number of resources. We have specific data here, etc. Next slide, please. And we also just launched today, thanks to Eric, a vaccine in long-term care resource page. So of course, we have a lot of information specific to COVID vaccinations and vaccines, but we also have information regarding the flu, and other vaccines. Next slide, please. And I just wanted to kind of start off the discussion today with a quick discussion about residents' rights. And as I mentioned in the previous slides, we provide a lot of resources on our website. One of the things that we do that I think is most valuable for, certainly for residents, I think, and families and ombudsmen, but also for care staff and for providers, is we have fact sheets, and this is one of them. We have them on a range of issues that we've identified as being particularly important to resident care, quality of life, and dignity. And each fact sheet, with a couple of exceptions, is a maximum of 2 pages, so easy to print out, easy to read, not a lot to, not an overwhelming amount of information, but it provides information on a specific issue. Here, this fact sheet is on informed consent. And the reason why I think it's particularly important for our discussion here is because there's been a lot of concern and a lot of controversy about the safety and efficacy of the vaccine. And it's important for everyone to know that residents have the right to informed consent. And this right is in the federal rules as well as in many state rules, but most importantly, it's in the federal rules. So every licensed nursing home in the country has to follow all the federal rules, and in addition to that, states can have their own rules that provide additional protections, but states cannot provide less protections. So here, I just wanted to again mention that we know there's a lot of controversy. People should understand that they have the right to receive a vaccination, and they have a right to decline a vaccination. And it is entirely up to the individual. When you go to a nursing home, your rights as a citizen or as a resident of the United States don't go away. Yes, we have to compromise when there is, when we're living in a congregate setting. We have to make some compromises. But compromises to our basic rights as human beings under US law doesn't go away. And just like I have the right to say I want a vaccination or not, as someone living in the community, so does a resident in a nursing home. So this provides some information on what it is, what it means to receive informed consent, meaning it has to be, and one has to be informed about a proposed treatment, including a vaccination, in a language that he or she can understand. One has to have, one has the right to learn about alternatives, their risks as well as benefits, and again, to make an informed choice. So this is really important. Personally, I will get the vaccine when it's made available to me, but I strongly support the right of residents or their families or their spokesperson, if another person has the right to make decisions for that resident, to say yes or no based upon what they want to do and what their beliefs are. So this is one example, again, of one of our fact sheets. Everything is free. Everything is free to use and share. We know family councils use this, ombudsman programs use this, attorneys use this, and even providers use this. So they're really, I think, pretty handy information and resources for people. Next slide, please. With that, I want to hand things over to Beth Nivin. She is our special guest speaker today, and I'm honestly, truly thrilled to have Beth here today. She is, I read through the program, and it's really, through her slides at least, and it's really superb. And I've spoken to Beth a number of times now. She's generously offered to provide this program. Beth worked as a research scientist for the New York City Department of Health for close to 30 years, first in the Bureau of Tuberculosis Control, where her emphasis was on monitoring of patients with multi-drug restraint tuberculosis, and later in the Bureau of Communicable Diseases, where she conducted surveillance for influenza activity, as well as assisted long-term care facilities with influenza outbreak management, which is normally the main challenge that we see this time of year. Of course, COVID has changed that significantly. She retired a couple of years ago, but she still works as a consultant to the city. This is really wonderful, is that Beth has also worked as a long-term care ombudsman in facilities in her county for the last 3 years. She holds a master's degree in public health from from the Tulane University School of Public Health, and she got her start in public health while working as a tuberculosis control officer in Botswana in Southern Africa as a member of the Peace Corps. So without further ado, I'm going to hand this over to Beth. Thank you, Beth, and welcome.
Hi, thank you so much for having me. This is my first Zoom presentation, so just bear with me.
Sure.
Here we go. Okay, so as you know, I'm not a physician. I have a master's in public health, but I've worked in many different aspects of public health. My favorite work is working in nursing homes, talking to staff about influenza vaccination. I've done that for about 20 years. I've visited almost every single facility in New York City multiple times to try to debunk the myths around influenza vaccine. As you all know, influenza vaccine has a life of its own in terms of myths and hype. So I try to really break it down, and I want to do sort of something very similar with the coronavirus vaccine. This slideshow is based on things I've read, podcasts, popular media, CDC, and other websites. So these are all accessible to many people, and I'd be happy to share the things that I've read, where I've read them. The bottom line is that nobody knows everything about anything. So there's still a lot of work in progress about many aspects of COVID and COVID vaccine. And I've geared these slides as a question answer format based on questions that I've heard, and I'm going to try to answer as many questions as I can, okay? So first, I want to know what happens when we actually get infected with a pathogen, either a virus or a bacteria. When germs invade our bodies, they start multiplying, and the more that we have is the more symptoms that we get. Our body sees these invaders as foreign, and they start fighting them by making antibodies of some sort. Once infected, these antibodies take a while to make, either days or weeks, before you start having this battle between the germs and the antibodies. So again, once we get infected, our body makes these antibodies, and should we encounter the pathogen again, our bodies have a memory function, and they know that we've already seen these pathogens, and so the next production of antibodies is very quickly. So we have this initial infection, our body sees these, whatever pathogen is foreign, they make antibodies, and then they keep a memory of that antibody. So what is the vaccine? So vaccine is something that stimulates the production of antibodies without having us need to get infected through the natural means. Our vaccine gives our body a heads up for something that you may see in the future by having our body start making antibodies against this. So vaccine is a boost for this antibody response, and it keeps it in our memory of antibody protection. So how do vaccines work? So vaccines, again, they help our body develop this immunity without having to get the natural infection. Our body recognizes that the proteins made through the vaccine instructions are foreign, and being foreign, they start telling our body to start mounting an immune response in the form of T lymphocytes and antibodies, so that if we're ever infected again with the same kind of pathogen, the memory cells will recognize them and fight the virus. Again, it takes a few weeks for the body to produce the B and T lymphocytes that we need after both infection and after vaccination. So again, this immune response is not immediate. For some pathogens, it's shorter, for some it's longer. So what vaccines are available for COVID-19? So right now, there's actually a variety. There's one called the vector vaccine, which you're familiar with flu, which is a weakened or attenuated version of a live virus, and that's what the flu vaccine is. The flu vaccine is a very, very attenuated virus. It cannot replicate, but it does make our body go into some kind of mode where it starts making antibodies against the virus. So you have the vector vaccine, a live or attenuated virus. You have a protein subunit, which is a part of the vaccine. And then you have this thing that is sort of new to people called mRNA. And that's the vaccines that are available in the US right now, made by both Pfizer and Moderna. So people want to know, this mRNA is such a new technology. What is it exactly? So it's not really quite new. This has been around for about 30 years. And definitely since 2005, there's been a lot of work being done with mRNA, both for a variety of vaccines as well as possibility for cancer treatments. This mRNA, if you remember in your biology, you have DNA, you have RNA. The DNA is the genetic code. The RNA is a subset. mRNA is a subset of RNA. It gives our cells the genetic code, the instructions to make a certain thing. And the certain thing that this vaccine is giving us is instructions to make the spike protein on the coronavirus. If you've all seen a picture of the coronavirus, this little ball with these little spikes coming up, it's this spike protein that actually allows the virus to penetrate the cells and cause infection. Without a virus being able to get into the cells, you really don't have disease. So this mRNA that is synthetically made in the vaccine, it gives our cells the genetic code to make the spike protein. Our cells then make the spike protein, but our immune system says, whoa, this is not a regular protein, this is a foreign protein. And so our bodies start making antibodies against the spike protein that we've been instructed to make through this mRNA. So our bodies now have a way to make antibodies against the spike protein, and our bodies remember this. It's called a memory function, so that if we ever encounter this kind of protein again, like when COVID actually does infect our body goes into memory mode and starts making these antibodies to fight this particular spike protein. So people want to know, so what exactly is this mRNA? What is it going to do when it gets into our body? And the thing is that the mRNA doesn't enter the cell nucleus, so it doesn't interfere with our DNA. It stays in the cytoplasm. If you remember your biology, there's these things called ribosomes. The mRNA starts giving out instructions for whatever protein it needs. It stays in the cytoplasm. Our cells break down this mRNA pretty quickly, but not until it's finished giving us the instructions. So again, you have the synthetic mRNA giving our body instructions to make the spike protein. And after a few days, this mRNA really degrades and leaves our body. So again, once again, it's not a live or inactivated COVID or any other kind of virus. And so it cannot really make you ill with COVID. This is just a very, very small synthetic component that makes our bodies make the spike protein. So people want to know, so what exactly is in this vaccine? And the answer is, it's really pretty simple for how complicated the vaccine is. It's got a really simple list of components. One is the mRNA, again, the synthetic compound made. The mRNA has to come into our cells in a certain way. And so it comes in enveloped by these lipids. These protect the mRNA, otherwise it would be broken down before delivering this genetic code. The lipid portion is actually a very, very fragile thing, and that's why the storage is needed at such low temperature. There's a tiny amount of this thing called polyethylene glycol, PEG, which is needed to maintain the integrity of the lipid molecule. It's not found in other vaccines, but it is found in other things that we encounter, like in laxatives and the bowel preparation you need for colonoscopy. And just keep this in mind, because I'm going to come back to the PEG component later on. But PEG is part of this lipid portion of the vaccine. What else is in the vaccine are salts and sugars that we encounter all the time. They're needed to keep the pH balance and to protect the vaccine during freezing. So basically, this is the full list of components in the mRNA. So people want to know, so is it worth getting it? What protection does this vaccine actually provide for me? And the answer is, according to the phase 3 trials for both Moderna and Pfizer, really good protection, over 90%, even for people over 65. And I just want to contrast that with the flu vaccine. Every year, it has a different level of protection. In a good year, flu vaccine protects you about 60%. Some years it protects you somewhere between 20 and 30%. But here are vaccines that are reported to protect you at over 90%. For the Pfizer vaccine, after the first dose, you got some protection, over 50%, 94% after the second dose. And again, just to give you an idea of the age group, the phase 3 trials included people up to age 85. So there were no nursing home residents involved in the trial, but there were people that were older. And even for people that were older, they got really good protection, over 90% after 2 doses. With the Moderna vaccine, it's not, I don't know the exact numbers, but it had higher protection after the first dose. And again, after both doses, you get over 90% protection. And the protection is against having symptoms, severe illness, and God forbid, death. It's not clear whether you get protection totally against infection, which means that people might get infected, not have symptoms themselves, but go on to infect others. And with corona, we heard that people infect others without showing any kind of illness themselves. This is true for other things as well. For flu, in fact, half the people who get flu infection don't have symptoms, but go on to infect others. So this whole notion of asymptomatic shedding is really pretty big in how people transmit both flu and corona. The Moderna vaccine is not proven yet, but it may have some protection against getting infection, which means that it really may protect against asymptomatic transmission, which is a really, really big boon in the whole transmission, in the whole issue of minimizing transmission. So that amount of protection, really pretty good. So people want to know, okay, so I get protected. What happens to me though when I get the vaccine? What could happen to me that's bad? And again, there's a lot of hype out there, and I'm just going to try to break it down a little bit. So approximately 15% of all the people in the phase 3 trials got a mild or moderate short-lived reaction after getting the vaccine. And this could be fatigue, muscle aches, headaches, fever, or pain at the site of injection. This occurred within a day or two after the vaccine administration. It was said to occur more so after the second dose. These reactions really mean that your immune response is really revving up. So for some people, they think that this is actually a good thing, that it means that you're responding in some way, and the response manifests as these very, very mild, short-lived reactions. And again, a lot of people feel that with Tylenol, these go away. So these, you do get some kind of short-lived, mild reactions within a day or two after the vaccine administration. Again, not everybody, but about 1 out of 7 people experience these kind of reactions. But people say, I've heard about much more severe reaction. What's going on? So again, the press is on top of this. So there's this thing called anaphylactic reaction. It's a severe allergic reaction that occurs very, very shortly after getting a vaccine, after getting an exposure actually to any kind of allergen. And 5% of people in the US have ever had an anaphylactic reaction. This could be to shellfish, to wasp bites. People get anaphylactic reactions to something. And anaphylaxis has been linked to some vaccines at a rate of 1.3 per million doses given. Again, pretty rare. With Moderna and Pfizer so far, we think that out of the, and again, my data is from last week, out of the 4 or 5 million doses given at that point, there was a rate of anaphylaxis at the rate of 5.5 reactions per million doses. Again, rare. None of these were fatal. Again, when you get a vaccine, you have to be in some kind of medical monitoring area for 30 minutes, just in case you do get anaphylaxis. And the people who got this reaction, they were taken care of immediately, either with their own EpiPen or through a shot of epinephrine. They all did very well. And when asked if they would get this vaccine again, they all said probably yes. So why didn't we see anaphylaxis in the clinical trials? Why are we just seeing it now for the first time? So the thing is that anaphylaxis is a very rare event, as I just said. It occurs in a few cases per million. And again, as of last week, out of 4 or 5 million doses administered, 29 cases. The clinical trials involved approximately 50,000 people. This kind of reaction is so small that it may not have been seen in a relatively small number like 50,000. And also, when people volunteer for these clinical trials, some people with a previous allergic reaction, they have self-selected out and have opted not to volunteer. So again, this could be why we didn't see anaphylactic reactions in the clinical trials. So people hear about other things that happen. One is Bell's palsy. And I've seen this in a little bit of the literature. So what is Bell's palsy? It's a facial nerve damage, inability to move half your face, resulting in what's known as a drooping face. The symptoms usually resolve within a matter of a few weeks or a few months. And this occurs spontaneously in the population, usually after some kind of viral infection like a cold. And it occurs at a rate of about 15 to 30 per 100,000 people. So did it occur in the clinical trials? The answer is it did. It occurred 4 times in the Pfizer vaccine arm and 3 times in the Moderna vaccine arm. So a total of 7 cases out of about 30 or 40,000 people. And if you look at the line above, it's within the incidence of the regular background rate. So there was no increased incidence of Bell's palsy after having taken either of these vaccines. There was Bell's palsy, it's true, but it occurred at the exact same rate as it occurs spontaneously in the general population. So a lot of people should get the vaccine, but there's some people who may not be able to get the vaccine right now. So anybody who got the vaccine and got a very bad reaction to the first dose should not get the second dose. And this is where I just want to come into this whole thing about polyethylene glycol. I said it's found only in these 2 vaccines, Moderna and Pfizer. It is found in other things. It's not clear what caused the anaphylactic reactions in these 29 people who got it, but it may be polyethylene glycol because it's not seen in other vaccines. It's not clear. So anybody who has a PEG allergy should not be getting this vaccine right now. If anybody has any question, it's best to see their allergist or immunologist. But right now, anybody who had a severe reaction to the first dose of either Moderna or Pfizer should really not get the second dose right now. And anybody with a PEG allergy should not get it also. And if anybody has any severe reaction like to shellfish, they should really see their allergist and immunologist first before they get the vaccine. Who should take precautions? Anybody with allergic reactions to other things like a peanut allergy, anybody who knows that they themselves have had other reactions, they can still get the vaccine, but wait around in the medical monitoring unit for 30 minutes or see their allergist, immunologist, just to make sure that they should get the vaccine at this point. Anybody with allergies to oral medications, family history of allergies, they can still get the vaccine. But again, staying in the observation area for between 15 and 30 minutes is really recommended for anybody, especially anybody with any kind of allergy history. So people want to know, wow, this vaccine got made so fast. What happened with the shortcuts taken? How do we know that it's really safe? So the answer is it really was a great confluence of factors that got this vaccine out to the marketplace so quickly. Operation Warp Speed was really great at providing both money and a lot of regulatory help in getting the vaccines made. Vaccines are usually made during sequential steps. You have phase 1 in a small number of volunteers, phase 2 and more, phase 3 in the larger number of volunteers. So what Operation Warp Speed was able to do was to have the vaccine manufacturers start making vaccine at an industrial scale even before the demonstration of complete safety and efficacy. This normally would be a great financial risk for companies, but with Operation Warp Speed, they got the financial backing to do this right away. Regulatory people got together with manufacturers. A lot of different advisory committees got together to analyze results. People who normally didn't speak to each other were speaking to each other. So this is really a great collaboration among many different organizations. And again, to get this emergency use authorization, EUA, a lot of things have to be answered regarding all aspects of vaccine production, and they were. So there were no shortcuts made. It just was a great confluence of collaboratory factors that made the vaccine get produced so quickly. So people want to know, can I get the vaccine if I already have COVID? So if you currently have COVID, you need to wait for the symptoms to resolve before getting the vaccine. But even if you have had COVID, the vaccine may provide additional protection because it's not clear for everybody whether the antibodies levels are there or how long they persist. So again, there's still all this unknown questions about what happens with antibody protection with COVID. So it's still a good idea, whether or not you've had COVID, to get the vaccine. So how often will I need to get the vaccine? So you know that with flu, you need to get the vaccine every year because every year there's a new flu variants out there, and you have to have the flu vaccine that matches the variants that are circulating. With the COVID vaccine, we don't really know much about how long antibodies last. The people in the vaccine trials, they got the vaccine more than 4 months ago, so we have 4 months of knowledge right now. The people in the clinical trials are going to be tested every few months. They'll be doing antibody levels on them for about 2 years. So we'll know moving forward how often they will have antibodies in their body. So again, it's still a work in progress. It's not clear how long antibodies will be available and when we need to get the vaccine. So people want to know which vaccine is better, Moderna or Pfizer, and the answer is we don't really know. And whichever vaccine is available is the one that's better for you. Right now, there are only 2 vaccines out there that are available. The UK just started using AstraZeneca. So the other vaccines actually have different components. AstraZeneca is the DNA vaccine, and that works a little bit differently. Janssen and Novavax also, they are either DNA or protein particle vaccines. And because there are different components in these vaccines, people with very severe allergic reactions who are going to defer the Moderna, Pfizer vaccines now may need to wait until some of these vaccines come to market to see if they fare better with those vaccines. So when will vaccination be available to me? And the answer, again, it's still a work in progress. Right now, the CDC and the state came out with 4 different phases. Right now, we're in phase 1A and 1B. Phase 1A was the one that included nursing home residents and staff. And just to give you an idea, most facilities have already had their first round of phase 1. In nursing homes, there were 3 rounds. Round 1 was for all residents and 1/3 of the staff. Round 2 was the second dose for residents and for the staff, and pick up people who didn't get it on round 1. And round 3 is to finish second dose of everybody who got it in round 2. Turns out that in the New York City facilities right now, about 30% of residents have declined vaccination right now, and about 56% of healthcare workers have declined vaccination right now. It may be that that healthcare workers were looking to see what reaction the people who went in round 1 had before they themselves volunteered to get in round 2. So we're starting round 2 vaccination, I think, this week. So we'll find out if more healthcare personnel are going to be getting the vaccine. As you heard, this week, we're starting phase 1B, which includes a lot of frontline workers, teachers, firemen, grocery clerks, whoever's out there, as well as people over 75. And I heard today that CDC is thinking about changing this to include anybody over 65 or older, and anybody, no matter what the age, with underlying conditions. So again, phase 1B might include other people. Phase 1C includes other essential workers and people like me in the 65 to 74-year-old age group. We don't really know when phase 1B will finish because there is a huge demand right now. There are about 2 million people in phase 1B that are eligible for the vaccine. So I know that the vaccination appointments are really being filled up quickly. So when everybody will get it, then in phase 2, it's really not quite clear. It could be a matter of weeks, months, I'm not sure. And nobody really knows right now. All we know is that New York City is ramping up its vaccination sites, and some of them will be going 24/7. So people want to know, okay, so I've gotten the vaccine. Why do I still need to wear a mask and that and social distance and do all that stuff? So there are a couple of answers to this. One is that after vaccination, it takes a few weeks for the body to produce B and T lymphocytes. As I said, After the first dose of the vaccine, you have some protection over 50%, but not total. After the second dose, you get your full protection. But again, it takes a couple of weeks after each dose for your virus, for the immunity to start ramping up. As you know, with flu vaccine, it takes 2 weeks for your body to ramp up. So again, here it takes a few weeks, and during that time, you're not fully protected. So if you get infected during the time that your body is still ramping up its immune response, you could get infected while your body is just in this process of building immunity and go on to develop symptoms. And again, because it's not yet clear totally if the vaccine protects you against asymptomatic infection, you could still get infected, not get clinically ill, but go on to infect others. So again, for these two reasons, there's still the recommendation in place to wear the mask even after vaccination. So the final analysis, nobody can force you to get the vaccine. It's only something you can make, and you need to look at the risk-benefit analysis, and I want you to do that based on the science, not based on myths and fake news. Again, the vaccine gives you 1 or 2 days of a mild, some kind of reaction, versus this reported efficacy of 90%. So you have to weigh your risk. The risk is your own risk of exposure, your risk of coming down with a severe illness given your underlying conditions, your unknown risk of allergic reaction, and that is sort of mitigated by being in an area where you're medically monitored for 30 minutes. So you have to weigh all the pros and cons, and only then can you make a really informed decision on whether or not to get the vaccine. I've hoped I've helped you by sort of looking at some of the questions that people have asked me and that I've heard asked about what's going on with the vaccine. And I'm hoping to sort of mitigate the hype that's out there. And I just want to just say a word about flu. There's a lot less flu this year than previous years. And part of that is because we're wearing masks, we're social distancing, we're not going out. So these are good things. But flu could extend through April or later. So it's really not too late to get the flu vaccine even now. And pre-COVID, again, things are so different this year, but pre-COVID, flu really did a lot to people. About 1 out of 5 to 1 out of 10 of all adults, and about 40% of children in the US got flu infection every year. About 250,000 people were hospitalized every year, and half of those were people over the age of 65. And every year there were a number of deaths with flu. And that number changed every year between 3,000, 40,000, 60,000, but most of the deaths were in people over the age of 65. So again, flu can still be a killer. I mean, COVID is really what it is, but flu in previous years has been a very severe cause of both morbidity and mortality. So again, I get my flu vaccine as soon as CVS gets it in. So not too late to get the flu vaccine. So with that, it's the end of my talk. And that is it.
Beth, thanks so, pardon me. Beth, thanks so much. That was so interesting and informative. I really appreciate it. I'm sure others did. I'll give you a hand. No, can't see anyone else, but again, very much appreciate it. I'm going to open it up to Q&A, and we did get a number of questions in, which I will read out. But before we do that, I just wanted to thank everyone who joined us today, both in the Zoom program and on Facebook Live. Our next webinar is February 16th, again, a Tuesday at 1 p.m. Eastern, and it's on the inappropriate institutionalization of people with mental illness in long-term care facilities, history and recommendations. And we have another guest, a special guest speaker for that program, Nina Lowenstein. And Nina is a longtime advocate for disability rights in New York, and generally speaking on long-term care reform in New York, and she works in other states as well. So I'm very excited about that. I think we're going to put the link to that program in the chat. I think someone just did that. And then it's also, if you go to nursingHome411.org, our website, click on the Learning Center and click on the webinars. You could sign up for that or any future programs. Next slide, please. So I'm going to open up for Q&A. Before I do that, we have about almost 20 minutes, which is great. Again, for updates and invites to future programs, please sign up www.nursinghome411.org/join. And then we do offer Amazon programs to provide this as a credit for staff and for volunteers as an hour of training. If you have, if your Amazon program allows for credit, you can take a very short survey at www.surveymonkey.com/r/LTCCC-LTCOP1, and that's on the screen as well. We will leave that up there. A number of people have asked whether this program is available. The program is available. The slides are available on our website now, and the program will be posted by the end of the week on our YouTube page, as well as on the webinar page of our website. So without further ado, I am going to turn to questions. So one person asked, when will there be enough data to determine if the vaccination will allow for safe, consistent visitation in long-term care facilities?
That I do not know that answer at all. There is still a lot of COVID right now in nursing homes. Right now, part of my consultancy is working with nursing homes around COVID positives. Everybody so phase one has ended in the vaccines. There's still a lot of COVID around, so it's really not quite clear. It's something that the New York State determines with the regulatory people. I do not know. I really feel very much for people who have not seen their loved ones. It's not a determination that is made easily, and I really do not know. It's something that is definitely not that the New York City Department of Health has any input into. It's coming from the state, and I hope that there's enough data very soon to answer that question, but I do not know.
Thanks, Beth. And I would just echo what Beth's response was. I think that there are so many variables, and I wanted to to mention that too in today's program, that we are seeing things both in our home state of New York and in states across the country that are really varying from community to community in respect to how this is getting to nursing home residents and staff, and the numbers of residents and staff that are accepting it. I know we have some questions about, Ombudsman and others getting access to this. So all those things relate to this question, and they relate to, in essence, how we are going to move forward. And visitation is, a number one in so many people's minds, and rightfully so. As this person said, who asked the question, some haven't seen their loved ones for almost a year, and their loved ones are not being protected as so many of the staff are testing positive. And that is extremely concerning. I just want to quickly say that this is an area that we and other advocates have been advocating on for several months now. We have been able to work, I think, fairly effectively with CMS, the Federal Centers for Medicare and Medicaid Services, to make clear that residents and families have a right to have visitation for compassionate care. That compassionate care doesn't just mean imminent death. And but unfortunately, some of the states, including our home state of New York, tends to be lagging behind in implementing those policies. But I strongly recommend that people use that CMS guidance. We do have it on our website. We have other information and resources to help you advocate. But the compassionate care visitation, I think, if your resident is declining, as CMS said, if they seem out of sorts, if they're not eating, et cetera, if they're declining, as I said, declining in some way, those are things that we should be pivoting to, making sure that they get visitation. Next question is, and again, I see there's some chat coming in. If you have a question, please put it in Q&A. We'll try to answer what we can in the next 15 minutes or so. If a resident refuses the vaccine, does the nursing home have the right to discharge or segregate the resident? Beth, I don't know if you want to answer that. If not, I could take a stab.
I just want to say one thing, that in the phase one visits in nursing homes, I said that there's a 30% refusal rate among residents, but those numbers, it's a huge spectrum. In some facilities, more than 2/3 of the residents refuse the vaccine right now, and more than half the staff. So I doubt that anybody in nursing homes are going to be taking any action against refusals among the residents. I don't think that is possible.
Thanks, Beth.
I have not heard anybody talk about what happens if a resident refuses. It's totally their right, and I doubt that anybody is thinking about discharges or segregating residents who don't take the vaccine. It doesn't happen with flu.
Right. And I hope that's the case. You know, and unfortunately, what we've seen is that just over the past 9 to 10 months, that facilities have, some facilities, I should say, have taken advantage of the COVID-19 pandemic and even greater relaxation in enforcement to kick residents out for whom they didn't want to provide care, to bring in residents who, you know, to all the issues that we see. Those of you who are ombudsmen or advocates know that the inappropriate discharge is the biggest complaint that that residents and families have with the ombudsman program nationwide, and it's a huge issue in every state that I'm aware of, and on a national level. So I think that we need to be very careful in monitoring and assuring, as Beth said, that residents have the rights. And as I said at the very beginning, and that fact sheet noted, residents do have the right to say no, and it's the facilities, you know, it's the expectation of the facility that they are going to be properly caring for the residents that they've accepted and for whom they're getting paid. The next question is, I did antibody tests on my mother. She is a 4.1. Does she need a vaccine? I'm getting mixed answers. I'm not sure what that 4.1 is.
So again, I'm not a clinician, but I could just tell you that if somebody has a high level of antibodies right now, they can definitely defer the vaccine for a while because they're protected right now, but we don't know how long those vaccines last. So again, what I said before is that people, even if they've had COVID before and have antibodies already, they can choose to get the vaccine now because the vaccine will give them added protection, or they can choose to wait. Again, nobody really knows how long antibodies last after a natural COVID infection. So your mother can elect to get the vaccine now, or she can elect to wait. And some people said that people with high antibodies, maybe they should wait to give other people a chance to get the limited number of doses, because there isn't a lot of vaccine to go around for everybody. So if you or your mom feel comfortable waiting, you can do that, or you could get the vaccine. I mean, it's mixed in the sense that your mother can benefit getting it now, or she could benefit by waiting a little bit. Again, I'm not a clinician, but we know that there is antibodies, but we don't know when they'll start to decline. That's still a big unknown. So again, your mom has the option of getting it now or waiting.
Thanks, Beth. This one I think might be right in your up your alley. We had some nursing home residents denied the vaccine from a pharmacist because they had a TB test recently. I know you have a background in TB. Is there any reason why they can't have the vaccine if they were recently tested for TB?
None that I know of. The TB test has nothing to do with COVID. I mean, I think that if they had the TB test already and the test was already red, I don't see how it could interfere with a COVID vaccine at all. I mean, there are questions about whether or not you can get COVID vaccine in the same day as another vaccine. And I think medically they want you not to do that, but to get a TB test, and recently, I don't know what recently means, I would go back. I will take that up with the state, and I could get back to this person. I have no idea why there should be a contraindication. I have not seen it, but I will find out.
Okay, thanks. Thanks. And we could post some answers on our Facebook page, which is I think facebook.com/LTCCC. You could join us there and visit that. We'll post any additional information or answers from Beth. Now you kind of answered this, but I think maybe it's worth repeating. This is someone who asked, if you have a shell allergy, should you take the COVID-19 vaccine? So I'm going to kind of group together, allergy questions again just for you to reiterate that, because I think it might be
Right.
worthwhile.
So again, that's something you should discuss with your allergist. A friend of mine who has a shellfish allergy asked me this question many times. She went to their allergist and he said she could get the vaccine, but I cannot speak for you. You have to speak to your allergist or immunologist before you take the vaccine. Only your doctor could really respond to that question. My friend did ask that question. She was told she has COPD, so she's at high risk of having a severe outcome if she gets COVID. So her allergist told her to take the vaccine and be monitored in a medical setting. Again, you should really speak to your allergist or immunologist about that.
Thanks, Beth. I just want to quickly interrupt. I noticed some of the chats coming in, and again, all questions, if you want them responded to, they must go in the Q&A, but I know some people asking about the survey. So we invite all Ombudsman programs to, essentially let us know if they are considering this to be a training. So you only need to take the survey if you have been told or believe that your Ombudsman program allows this to be a training. We do monthly webinars, and we welcome the Ombudsman to use this as trainings. And then we will list your area or Ombudsman program once we do that. So I just hope that quickly clarifies. A couple more questions. We have some time. Good, because we have a lot of questions. Are Ombudsmen considered responders eligible for the vaccine? My understanding is they're not. So I don't know, Beth, if you know of anything
No,
different.
probably not. But again, they keep changing a little bit who is eligible in which phase. So I mean, just keep looking. But it's really now for people that are going to have some kind of contact with the public in some way. So I think in the near term, probably not. But again, the list keeps expanding about who's eligible when.
Thanks, Beth. I recently read that people shouldn't take ibuprofen or acetaminophen a few days before the vaccine because they can interfere with its effectiveness. Is this true?
I have not heard that. I've heard of people who actually do take ibuprofen before because they know that they're going to get a little bit of sort of site of injection. I have not heard that at all. I don't know why it would, but again, I could look that up. I just know that people have opted to take one of those on the day of the vaccine to mitigate the reaction that they think they're going to get. I could look it up, but I don't know the answer to that one.
Thank you. So I have, second question is, next question, excuse me, I have type 2 diabetes. Why does that make me a higher risk versus a person who is just older?
So that's a good question. That's why the CDC today is looking to expand the list of people to both those over 60, 65, and those with underlying conditions. When they've done studies looking at people who've gotten very sick with COVID or who've died with COVID, they found that type 2 diabetes is a risk factor for severe outcome. And so it makes you higher risk. It makes you higher risk than a person who's older with no underlying conditions. So type 2 diabetes is what they call one of the really, really high risk conditions for severe COVID outcome, along with hypertension. I know that because my husband has type 2 diabetes, and we're waiting to hear when he could get the vaccine, because that's his number one fear, is that the type 2 diabetes will make him get a worse outcome with COVID. So for some reason, the type 2 diabetics are just shown to be in a category of severe, there's something with the immune system in diabetes that makes the immune response make for a more severe outcome.
Someone asked what determines which vaccine you receive, and I think that just is based upon the availability in the community through CVS or Walgreens in respect to the what's going on with long-term care. Someone else asked, given the currently low response vaccination rate among healthcare workers, how do you see that impacting restoration of normal visitation rules at nursing homes? And I'll answer that. I think it's going to have a significant impact on, and it's something very concerning that if we have a lot of staff in particular who are not getting the vaccine, that, you know, and as Beth said earlier on, we don't know how many months it'll take before people in the latter phases will have access, which will include a lot of family members. I think we probably won't see, you know, fairly open visitation until there is enough people who've been vaccinated that we have some kind of herd immunity, as you hear people say, and not the herd immunity that we've heard the president talk about, which is people just die off and survival of the fittest, but that herd immunity, meaning that enough people have received the vaccine so that the population as a whole has been pretty well safeguarded. So I think kind of a long answer to your question, but I think that we really need to see down the line a stronger ability to prevent transmission of the virus. Thank you. Okay, it's 2 o'clock and we're going to wrap up now. We'll try to respond to more questions, perhaps quickly in writing if we can. I don't like to make promises with someone else's time, but because we really appreciate Beth so much sharing her time with us today and her knowledge and expertise and her obvious caring for residents and for the public in regard to these issues, excuse me. So thank you all very much for joining us. Again, this recording will be made available on our YouTube channel as well as on our website. Please do join us on YouTube, on Facebook, and in our podcasts, which are really great. Thank you again, Beth. Thanks everyone for joining us. Wishing you all a happy and a healthy and a safe new year.